So I'll take over. I guess I can start a little bit early. Just a quick note here that I'm going to try some electronic polling and diagrams. So if you want to go on your computer's devices to this web address, and I'll show it again very briefly again. Or you can even text answers to if you sort of start your text chain with this number here. Oops, 1 second there. We'll swap those. So there. Hopefully you can hear me and you can see my slides as they should be. I'll just do a quick introduction for myself. So my name is Kevan Mehta. I'm a pediatric respirologist and sleep physician. I work both at McMaster Children's Hospital in Hamilton, as well as the Etobicoke Brampton Sleep Clinic here, and assistant professor as part of McMaster University. And I'm going to be speaking about parasomnia. So it's a little bit of a black box for a lot of providers. First defining what it is, how it factors into the sleep structure and ultradian rhythm, reviewing some of the symptom, signs, presentation of the more common pediatric parasomnias, and then kind of focusing on some important consideration and especially red flags for considering other things. If we have time, we may not to look at some rare uncommon ones, but I didn't want the focus of this talk to be, the kind of rare and uncommon stuff that you may not come across, focusing more on the common ones. So I'm going to try this poll. Let me see if I can get it going. Give me 1 sec here. We'll activate it for you. So hopefully that's coming up on your devices. And you can start to put in some answers to the question of what you think a parasomnia is. And then I will share that. And so hopefully you can see. We can see if answers come in here. Are people seeing answers? There we go. That works better. So you'll get a word cloud here, and the more someone puts a word in, the larger the font will go. So feel free to put repeated answers if you feel it's an important topic. I'll give you a few more seconds to do that. So we have nocturnal behaviors, unusual, obviously in sleep. There we go. Give you 10 more seconds. Anything else people want to add there? Talking comes up in there, yeah, movement. A lot of the word behaviors, and sleep is obviously very prominent. Movement disorders coming in there. All right, great. So I will switch back to my presentation here. And we'll give you the formal definition from the ICSD-3, the International Classification of Sleep Disorders. So they comment that parasomnias are undesirable physical events or experiences. So that's key as well, what the patient is experiencing during entry into, within, or arousal from sleep. So it can be really at any stages, encompassing complex movements, behaviors, emotions, perceptions, dreams, and autonomic nervous activity. So really broad, just kind of general definition if you're talking about parasomnias as a whole. And so the ICSD-3 does kind of categorize them, and we mainly use the kind of non-REM and REM-related parasomnia categorizations. And not going to go into all of these parasomnias, but there is the other category, which are the rarer ones, especially in kids, and then the isolated symptoms and normal variants, which is mainly sleep talking, as someone had mentioned in the word cloud. So let's go to the next question. So go back to your devices and we'll activate the next poll. So which of the following can be part of a parasomnia event? So we'll start to get some answers in here and I'll show you what's coming in. So we're getting a lot of all of the above. We'll give you 10 seconds, put your answer in quick. All right, so we got most people saying E, all of the above, and your answer is there. Oops, we'll have to switch back to the presentation. Your answer is there, all of the above. So yes, there can be a very broad range of things happening in parasomnias. Let's get you to the next question here. So this one will activate and then you can see the answers in question there. So go ahead and put your responses in. We'll switch you over to that question. So which feature during the event may help distinguish non-REM versus REM parasomnia? We'll give you 10 seconds to put your answers in. You can see a lot of people are choosing C. All right, and then I'll switch back to the presentation so you can see the answer is generally C. And we'll talk in more detail about these, the answers to these questions. Last question for this set. Switch you back over. So you can read the question there. We'll activate it and get you answering here. Right. So further assessment or polysomnogram sleep study for nocturnal events is suggested in which of the following cases? So events are rare, family history, no potential for injury or significant disturbance to the patient's home life. I think we're getting a lot of D. Give you 5 more seconds if you want to put your answers in. Great. So it looks like I don't need to give this talk because everyone knows everything. But yes, we generally will think of it more in this situation where there's a significant disturbance to the patient's home life. All right, so that's it for some of the questions for now. We'll come back to those. Just to make a quick comment that we talk about the circadian rhythm, which is the 24-hour cycle, sleep-wake cycle. And then the ultradian rhythm refers to the cycles within sleep, so even more focused on sleep. And then, that's quite important when we talk about parasomnias. We generally see more N3 or less REM sleep in the first third or even the first half of the night. And then you'll generally see more REM in the later third or later half of the night. So that will come in important when we talk about non-REM versus REM parasomnias. And that's where timing, is a key part of your history in discussing parasomnias. So physiology of kind of sleep in general. So although we like to look at REM, non-REM, and wake as kind of separate states of sleep, and there's kind of discussions that you go into very clear stages of sleep at each point. It's really more of a continuum and a very fluid process. You're going in and out of different stages. And especially when one stage overlaps into another, there can be undesirable consequences. And we think of these as the highest kind of risk times for when parasomnias can occur during the transitions. So, one example is when you mix wake and non-REM, you have some parts of the brain and some degree of arousal and wakefulness in the brain, but other parts in sleep and non-REM. And so, you can get some of these motor movements that we associate with wakefulness, like walking, but you're not fully awake. So, that's sleepwalking. And this is also when things like confusional arousals can occur and sleep terrors. Mixing REM and non-REM or wake leads to the REM sleep behavior disorder that we'll touch on in a bit more detail shortly. So this idea that you're sort of mixing states when you're getting a parasomnia type event. There's some discussion and theory over, what these parasomnias are and what they represent. And some theorize that non-REM disorders involve activation of basic drive states, so things like feeding, sex, aggression, but you don't have that activation of the prefrontal cortex that inhibits, the undesirable or not, recommended behaviors. So you often get these behaviors without that inhibition or control. REM behavior disorders often result from serious neuropathology, more so in adults. And the kind of very common quoted one is Parkinson's. So this tends to be the technically only kind of parasomnia disorder that people would generally want video evidence on PSG and more formal kind of measurement as opposed to history and clinical diagnosis. So we'll go to another multiple choice question, this time with some sort of a case-based question. So if you want to go back to your devices, that should be active for you there. So you see a 6-year-old girl seen by her pediatrician. Parent reports she wakes screaming, upset twice per week, lasting 3 months. Typically around 11 to midnight. What would your diagnosis be here? Oops. I'll give you a few more seconds to answer that, and we'll share the responses with you that are coming in. Oops. All right, so we had most people commenting on sleep terrors or night terrors, as they're often called as well. So we'll share back to the presentation. So yeah, I think that typically would be the most common diagnosis there. So commenting now on non-REM disorder, non-REM and disorders of arousal. So timing, it can happen throughout the night. So there's no absolutes when you're kind of taking this history on parasomnias, but they tend, the non-REM ones tend to happen with arousals in and out of slow wave sleep, so N3 sleep. And so that tends to be the most unstable in the first period of the night. So this sort of, 60 to 90 minutes after sleep onset tends to be the more common time where kids or people in general will have a parasomnia event. It can skip the first cycle. So just because it happens later in the night doesn't automatically mean it's not a non-REM parasomnia. So it can happen in the second or third cycle of slow wave sleep as well. So typically there is a kind of very automatic, kind of very common timing for these events. They tend to be milder over the course of the night. So most commonly it's a single event, but there are kind of unusual circumstances where they happen repeatedly within the same night, but they tend to get milder as the slow wave sleep is less and less, and the REM sleep is more through the course of the night. Don't forget that, or just to know that they are common in children. So I think, in the adult population, there's a different index of suspicion and concern over parasomnia behavior, but in kids, for us, it ends up actually being a pretty common discussion, and mainly not, mainly looking for red flags is our kind of approach. Confusional arousals, kind of 20% of children are quoted to have these. Sleepwalking is 40%. Sleep terrors up to 25 or 30% in kids under 5 years of age. Most of these behaviors decrease as the child gets older, but even, there's some residual people sleepwalking and having night terrors even up to kind of the teenage years. So not always something that's pathological or concerning. And as you see more and more kids, if you think about 1 in 3 kids having one of these behaviors, you pretty quickly could see a couple within a single clinic in a day, for example. In children, we generally know the vast majority are not connected with the pathology or future or present or future psychopathology, as opposed to adults where there is a higher worry about connection with kind of neurological problems. So we do label these mostly as benign. The diagnosis in these situations is mainly by clinical description, so it's not typically a reason to be doing a sleep study or really detailed sleep evaluation. Confusional arousals, the typical description is waking from sleep with mental confusion. This typically doesn't have the fear and sympathetic symptoms that you'll see in other conditions, and not generally walking. And the parent will commonly say, their child kind of sits up, looks around, and then goes back to sleep. So that's pretty common for a confusional arousal. Sleep terrors, most will be aware of kind of the description. There's abrupt terror on waking. There can be vocalizations and screaming, and there are signs of autonomic arousal. So dilated pupils, fast heart rate, tachycardia, fast breathing rate, tachypnea, and sweating diaphoresis. These obviously tend to be very worrisome to the parent. The child is usually not consolable or responsive. So a lot of people obviously associate this or think of this, that something really terrible is happening in the child's body or to the child. But in fact, it's benign in the kind of typical sleep terror situation. Sleepwalking, as you probably know, is an arousal associated with ambulation, so walking around, and can include some pretty complex behaviors when they get out of bed, as opposed to kind of confusional arousals and sleep terrors that have very basic movements mostly. On the PSG, so we had mentioned that it's not really required if you have a good clinical description without red flags. Some might kind of say there's a subtle difference on the EEG. People have looked at things like the cyclic alternating pattern, delta counts, arousal rates, especially in that first sleep cycle. We often, or we may see hypersynchrony if we capture them having an actual event. And main thing with the sleep study is whether sleep disordered breathing and or periodic limb movements are contributing to the unstable sleep and the arousal. So that's usually the main reason to do a sleep study in this context. Causes, it's a bit broad when you kind of span between adults and kids. There definitely is a strong family history component. So parents will often report that they sleepwalk or they sleptwalk as a child when we're talking about sleepwalking as an example. Anything that throws off your sleep cycle and sleep consolidation, so sleep deprivation, situational stress, anxiety. It is quoted to be connected to things like hypothyroidism, migraines, head injury, encephalitis. So usually a good clinical history should help to exclude those. And then the right side, stroke is more of an adult thing, but we have rare situations where kids have had strokes. Obviously obstructive sleep apnea if it's causing unstable sleep and arousals. Environmental stimuli, so things that wake the child up, and the jury's out on how cell phones and light from the electronics affect that. But definitely we are worried that contributes. And then possible connections, things like unfamiliar surroundings, travel, fever, PMS in older children and adults, medications, alcohol, distended bladder, and external stimuli come there again. So clinical history is important. As we mentioned, generally it's in the first 90 minutes, 60 to 90 minutes. Description tends to be kind of gradual with sleepwalking and confusional arousals as opposed to very acute and sudden with night terrors. And none of these tend to be responsive to environmental or reassurance. As I mentioned, there's usually one single event and the person is not arousable or responsive. And as as the multiple choice question alluded to, most will not remember these events. So the non-REM tend to be non-memorable events. Daytime impact, especially in the benign situation, is usually there's no effect. And most kids will not even have kind of excessive fatigue or sleepiness. Family history, as we mentioned, is usually positive, and especially in a first degree family member. So red flags and differential diagnosis, I think a lot of neurological things tend to arise if you're seeing parasomnias. The main kind of concern that we tend to get asked is whether there's a possibility of seizures. There's, some very rare and unusual seizure disorders that can contribute to complex movements, particularly frontal lobe seizures. Headaches, and migraines, as we mentioned, are connected to non-REM parasomnias. PTSD and anxiety are linked as well, so that could flag. And sometimes when you ask, if a child is having these parasomnia events, you sort of dig a bit deeper and you ask, well, what's going on at home or what's going on at school, and you actually get a story about bullying or kind of home environment stresses, and the parent may not have linked those two in their mind. Conditioned arousals and nocturnal dissociative states, nocturnal panic, are sort of a different category of sleep disorder. Nightmares is often the common one. So whether the child's having a true sleep terror or is it a nightmare, you want to differentiate that. If there are sort of confusional arousals or other movements, whether they're having sort of the rhythmic disorders, rhythmic movements of sleep. And then trying to differentiate non-REM versus REM parasomnias, and in particular, if it is a concern of REM parasomnias, if there is REM behavior disorder. So common differentiators from kind of parasomnias versus seizures. I'll just put this in a table for you. We ask, and you can kind of go through that. I won't speak too much or read the words, but you want to kind of differentiate between age. The timing can be a helpful differentiator factor. The sleep stage that they're in. I mean, you may not know that from the clinical history, but the parasomnias tend to happen in N3 as opposed to seizures in N1 or N2. The duration, where parasomnias tend to be a bit longer. The description of the events, with seizures being more stereotypical and repetitive movements. If you have EEG, or if this is happening in a setting where there's EEG, with seizures, you may see spike and wave or other abnormal EEG. Triggers, so there's overlapping triggers with kind of sleep deprivation and illness, but seizures seizures can also have photic components to them. And then daytime impact, it's more commonly that we see excessive daytime sleepiness and fatigue in kind of seizure disorders, either from the seizure disorder itself or potentially from the anti-epileptic medications that are used. So treatment of the non-REM parasomnias, for us, luckily in peds, it's mostly reassurance, as they're very common, as long as they're not associated with any red flags, and we can reassure parents that this does not predict any kind of present or future illnesses. The main problem that occurs in a lot of these parasomnia events is the safety of the child. So we have to give safety advice, and side note, to document that well in case there is an injury that happens from a liability perspective. Sleep hygiene is our main sort of treatment, quote unquote, making sure the child's getting enough sleep and has a good sleep schedule. So there's more consolidated sleep and less likely of a chance to arouse from slow wave sleep. For those that are having more significant problems or more frequent or severe events, there is discussion about scheduled awakenings. So waking the child 15 to 30 minutes before the kind of typical standard time that these are happening. The idea there is that you sort of wake them out of a more superficial state of sleep before they get into slow wave sleep, N3 sleep. And then maybe they skip over one cycle and the next cycle will kind of be a more stable sleep cycle that doesn't lead to an arousal and parasomnia event. However, if you mistime it, there is kind of reports of triggering an event because you're now actually waking them up out of slow wave sleep. There are some studies, not a lot of kind of positive supportive data, but just in terms of biofeedback methods and more sort of counseling psychotherapy, especially if we think there's a kind of comorbid anxiety or relation to social stressors, can be helpful as well. I'll pause there for a second before I go into REM sleep behavior disorder, if there's any questions you wanted to ask about non-REM parasomnias. All right, looks like I can continue. So we'll go into REM sleep behavior disorder as a kind of more of the common subset of REM parasomnias, REM-related parasomnias. So for us, I actually depend more on my adult colleagues and talking to them if I'm worried about this or thinking about this, because it is very, very rare in kids. It's more commonly seen in males over 50 years of age, and I'll let my adult colleagues maybe explain that. The prevalence in the overall prevalence, even between adults and kids, is kind of quoted between 0.5 and 2%. So not something we commonly encounter. And there is a strong association with neuropathology in those adult patients, things like Parkinson's, Lewy body dementia, and such. Often, again, when I talk to my adult colleagues, their patients may be on medications. Smoking is linked to it as well, previous head injury, and then farmers and pesticide exposure, thinking again to neuropathology that's at the root of this possible condition. And so the clinical picture here is the more sort of common one that comes out in the media or in kind of discussions of funny cases in sleep medicine, where there's dream reenactment. So this is often remembered. So that's kind of a key differentiator. Patients will remember the dream or remember what they were doing. And then it tends to have complex behaviors related to that dream. So it can include things like screaming, shouting, kicking, punching, sitting up, leaping out of bed, crawling, running. Often, patients will tell you that they were trying to fight off, bats, or you'll see those videos on YouTube. On the PSG, as Manuela was talking about with the scoring, we may see increased tone in REM, so REM without atonia. So that does raise the kind of concern that this patient might have RBD. And some people will even do expanded EMG montages to get a better sense of the significance of the REM with atonia. As Manuela had mentioned, you may not easily be able to get chin leads or even leg leads. So sometimes doing an extended EMG montage can capture more muscle tone data. There are case reports of children with brain tumors having RBD. So I think, you do have to have a high neurological suspicion if you think the history and some of the initial investigations are consistent with REM behavior disorder. And then where I've seen it more commonly is the patients I follow, again, not a large group, but the patients that have narcolepsy, pediatric narcolepsy. So I'm usually asking more focused questions to this population about the possibility of acting out their dreams at night. Often, as you might imagine, getting a clear story from a pediatric patient, if you say 5 or 6 year old, is not always straightforward. The parents may or may not kind of be going into the room and have corroborating history, so it can be a bit tricky. And then some people use this term REM sleep motor parasomnia, but because this area is pretty unusual and not well studied, there may be kind of different groups within what we call RBD or RNP. So just contrasting, as we said, sometimes it is very difficult to tell apart from sleep terrors. If the child's having either a bad nightmare and acting out the nightmare, or if they're just having an arousal that leads to a kind of night terror. Generally, there's usually vivid dream recall as opposed to no memory or little memory of the inciting event. There is memory of the episode itself too, that the patient remembers that they were doing these actions. For the most part, or kind of more prominent, is when it occurs in the second half of the night. As we mentioned, the non-REM parasomnias tend to be in the first third or first half of the night. And then if you're kind of looking at kids who already have a diagnosis, or you're concerned about the diagnosis of other neuropathology, for example, narcolepsy, as we mentioned, that might raise your concern for RBD. And treatment, again, I lean on my adult colleagues more. We haven't really had significant RBD in kids that I've seen or followed. The adults have used clonazepam with good effect, and we consider that as well in kids. However, one of the kind of main problems with benzodiazepines in general in kids is the effect on the developing brain. We don't really have good data or know about that. And number two is the hangover or sleepiness side effect the next day. So we may consider lorazepam a little bit more so in kids because of the shorter half-life. Interestingly enough, melatonin has also shown some efficacy in the literature. And then there are reported efficacy with other medications, things like pramipexole, which we think of more in restless leg syndrome. The Z sleep drugs like zopiclone, and then some of the, so donepezil is a medication used in Alzheimer's and dementia treatment, and then other medicines you mentioned there. And I actually found one paper on this Chinese herbal remedy, Yigan San. So very interesting if you go sort of digging through the literature, but very limited data, especially in children. So I'll give you another MCQ to wake you up here. Let me just activate it for you. So if you go back to your devices at that link, you can hopefully see this question now. And we'll see what answers come in. So a 15-year-old has RBD and then is also complaining about daytime sleepiness. What would you want to consider? We'll give you 10 seconds there. All right, we'll share the answers with you. So most of you had said narcolepsy. I think all are fair, so I'm not going to say it's right or wrong, but I agree. You know, for me, narcolepsy, I think would be one of the main ones I think of. But I wanted to make the question a little tricky, and all of those are reasonable considerations, you know, when you see RBD, especially in a kind of older child. Great. I will switch back to my presentation here. Right. So I was just briefly going to go through some of the other parasomnias, and I'll admit I don't think I have any patients that I have seen with these ones. They're the more sort of rare, unusual ones, and maybe we can, in some of the questions and discussion, get other people's patients and perspectives on these. So sleep-related dissociative disorder. So one of the challenges with this type of parasomnia is that the behaviors are similar to those that are seen in non-REM and REM parasomnias. Having said that, they tend to happen more so in any stage of sleep, still again in transitions, but often between that non-REM and REM transition to wakefulness. So kind of coming out of sleep. For whatever reason, it's more often seen in females. And this one has more kind of red flags or concerns. There are psychological symptoms during the daytime as well. So disturbed behavior, confusion, amnesia. So if you're kind of getting more daytime related concerns, this starts to come into your differential. On the sleep study, the EEG shows wakefulness before, during, and after these episodes. So that can help be a differentiator somewhat. And this tends to fall more into the sort of psychology and psychiatry treatment, especially for our kind of sleep psychiatry related colleagues. So psychiatrists who've gone into sleep medicine, they may treat and see this much more often. So it tends to focus on psychological and psychiatric approaches. So cognitive behavioral therapy, CBT, psychotherapy, and medications for sort of psychiatric disorders as opposed to some of those other medications we talked about for non-REM and REM parasomnias. I think I was going through the list in the book, so this sleep talking came in here. I probably should have put it earlier. So it's not kind of considered part of the regular non-REM, REM parasomnia framework, but it is a very kind of normal thing or benign thing typically. So considered a normal sleep variant. Usually the child or in this situation, there's kind of very calm and not any distress with the talking. 50% of children are reported to sleep talk at least once a year, so pretty common again. typically reported between the ages of 3 and 10, and then decreases over that time frame, or as the time frame goes on. In the PSG, it occurs in all sleep stages, but more prominent in the superficial stages of N1 and N2, a little bit more in N3, but it can also occur 25% of the time in REM. So a little less kind of predictable, or kind of showing that timing predisposition that we talked about with non-REM and REM parasomnias. Funny enough, again, there seems to be a genetic or family history component. So those who have parents that sleep talk tend to seem to have kids who sleep talk. And it may be associated with other parasomnia conditions. So especially things like confusional arousals and night terrors. So often we get parents reporting all of those together, not just kind of a nice clean cut, one or the other. Sleep enuresis. So this is technically an undesirable behavior in sleep, so falls into a parasomnia categorization, and then it's more formally defined as involuntary voiding at least 2 times per week for 3 consecutive months in a child of 5 years of age or older. So I think they're trying to determine what's kind of developmentally okay, where there's a transition from primary enuresis to a more pathological problem with it. It is noted to be more common in males. Again, a strong family history, and there have been associations with RBD sleep breathing disorders. Sleep-related breathing disorders is the term that was used here, and so resolution after potential treatment of this, in particular the treatment of adenotonsillectomy in most of our kids for OSA, or young kids with OSA, and they do report up to 60%, although I have to admit that's not really been my personal experience. I do get referrals from time to time that are solely focused on nocturnal enuresis, and not always, or no, I wouldn't say commonly, in just kind of my anecdotal experience finding OSA, but it is an association link and potentially helped by treatment of this. So people do mention about it being a disorder of arousal. So whether you're in a group that kind of considers it more of a bladder-centric condition or more of a sleep-related condition, there's kind of 2 camps. And as Dr. Bola had talked about, different pathophysiological mechanisms or theories of considering why nocturnal enuresis might happen in relation to a sleep disorder. Cataphrenia is one I put on here as well, because it is something that from time to time comes up. I wouldn't say common, but not uncommon. So a lot of, I have had quite a few parents tell me, their child groans in their sleep. And, it can be quite distressing because the parent thinks that the child might be uncomfortable or in pain. And so if you can kind of label it or give them this diagnosis, it sometimes helps to alleviate a lot of that worry and concern. And in particular, so cataphrenia is described as a groan, typically a deep inspiration followed by a prolonged expiration with a groaning sound, as opposed to pain that kind of is with breathing in and out and the child's uncomfortable. It's more common in adolescents. Nobody actually knows why it happens. There seems to be some complex activity from the brainstem with the kind of discoordination of glottic closure. And really, there's not much treatment that's either needed or been successful. So it does sometimes, most of the cases you read will be about, discussing treatment because it's disrupting a partner, so more kind of in the adult or at least older child world. So a lot of the times, we don't have to worry about this or treat this, but some adults, are disrupting their partners, will want treatment. And so some of these other medicines, trazodone, clonazepam, gabapentin, carbamazepine, neuromodulators in that sense. There are case reports of trying these and some anecdotal evidence that it might help. But I've never had to personally prescribe any of these for kids having cataphrenia. More often than not, the younger kids are sleeping alone and not really needing treatment because they're disrupting anyone with it. It's more of just a reassurance and explanation of what's happening. And then, this comes up pretty commonly in the sense that a lot of our kids, especially obese kids, parents are struggling with their kids eating in general, but especially at night. I just had two kids yesterday. We talked about this. The kid gets up and one of the kids actually cooks a whole meal for themselves, with the parent asleep, which is very challenging when you're trying to give advice about nutrition and keeping food healthy. So people will often kind of say, is this a parasomnia that they're eating at night? And more commonly than not, the child has full arousal and knows what they're eating and doing. But there is, a specific parasomnia eating disorder, sleep-related eating disorder. So this is, characterized by repeated episodes of eating and drinking without conscious thought or control. It is linked, or there are associations with all the sort of sleep disruptions we've talked about, things like OSA, PLM, sleepwalking, narcolepsy, eating disorders as well, circadian rhythm disorders, and then more so again in adults with some of the medications that patients might be on, like zolpidem and lithium, and more so, substance abuse, but more so at kind of cessation or withdrawal with those substances. Usually there's partial arousal. So the patients are able to do quite complicated movements and getting to the kitchen and opening the fridge and even making, simple meals and things like that. But they will mention no recall of the event. And that's kind of a piece that always is tough, that kids will often say, I don't remember eating that. And you have to really kind of dig into that and make sure that's truly the case, or they're just worried about, the punishment and the negative part of identifying that they were eating at night. There are reported injuries. Obviously, when people are preparing food or in a kitchen, there's a lot of dangers there. So, and they may not have full arousal in denoting what's edible and not edible. So reports of eating inappropriate foods or substances. One case report I read, a patient had raw chicken or raw meat without it being cooked. So, things like that may flag up more easily whether this is actually a parasomnia type event. And really on the PSG, not always that helpful again with parasomnia events, but you may just notice more frequent arousals from slow wave sleep. So that's all I had wanted to go through. I wanted to leave, this is a really broad area, so I wanted to leave a bit more time for questions, discussion, comments. So I'll take a little break there and give you a chance for any questions or comments. Thank you. If there's no questions, I may ask a question of you to the audience. I don't consider myself an expert in parasomnias, and us, for us in the pediatric world, there's very few of us who do. So for those people who also see adults or kids with more commonly having these conditions, maybe someone can share some of their experiences with parasomnias in their population.
Minutes coffee break. There's a coffee you guys can grab it and come back.
I'll stay on for any other discussion or questions, but if people do want to go for an early coffee break, I guess that's the other option.
Let them grab coffee and come back, and we can start whenever. Dr. Mehta,
So, Dr. Mehta, we will have one coffee break for 15 minutes, and after that we will start again.
It's up to you, Dr. Mehta, 15 or 10.
And Dr. Mehta, I have one question. Is catatonia is threatful, like life-threatening? Is there any definite treatment for that?
Yeah, so I mean, catatonia is considered a benign condition. So as much as it sounds distressing, or the patient, the parent or person around them thinks that the patient is in pain, it typically is not life-threatening or damaging to the patient. It really represents kind of closure of the glottis during expiration when the glottis should be open, and so wouldn't really cause any respiratory instability, anything like that.
Dr. Mehta, there is one question in the chat. Miriam, Dr. Miriam, I guess.
Oh, yes. So when does it happen? Yeah. So it is quoted as happening at any time through sleep. So there really isn't that much of a predisposition. When I tend to hear about it as best as I can, it more the more prominent thing is the patient groaning, in inspiration and expiration, or is it really focused trying to get that history of, is there kind of a deep breath in, a sigh kind of as the patient breathes in, and then is the event happening more so on expiration? That to me is more kind of specific when I'm thinking of catatonia, but can obviously be hard for someone to describe if they're not really kind of paying attention to that.
Excuse me, one question here. I read somewhere, I think in the Kaiser book, sleep book, about some sexual disorder during the sleep, and without any memory about that. Is this kind of parasomnia happening in the kids also?
Yeah, I mean, luckily, fortunately, not so much. As I sort of mentioned in the pathophysiology, and was alluding to that, some of the non-REM parasomnias are linked with basic drive states is kind of the theory, and one of those basic drive states considered in evolution is sexual behaviors. And I haven't fortunately had to deal with this in kids, but my adult colleagues have had situations where there is a recognition that there can be a sexual parasomnia, sexual behavior related parasomnia, and it does come up not infrequently in court cases. So it's a very tricky position to put a sleep physician in, because sometimes they'll be asked to testify if their patient committed a sexual act involuntarily or because of a parasomnia, as opposed to voluntarily or sort of it's a sexual abuse. So I don't have a lot of comments from my personal experience, just from my reading. And more often than not, those cases, it's being used as potentially a kind of wrong defense, or for kind of the patient or the person trying to use it as an excuse. I don't know if any of the people on the call on the Zoom want to make a comment on that.
Thank you, very interesting.
There was a direct message to me in the chat that